All right, here we go. Hello, everyone, and thank you for watching this presentation on modifiers. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information in this presentation is not intended to be a substitute for your thorough clinical decision making. It's not intended to be legal advice. Target coding does not engage in providing legal services. CPT is a registered trademark of the AMA. Every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. A little bit about myself before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I practiced for 16 years, and about 12 years ago, I started a company called Target Coding. I am a certified professional compliance officer. I'm a certified billing and coding specialist. My areas of expertise include compliance as it relates to billing, coding, documentation, Medicare, HIPAA, and compliant cash plans. I've written 12 documentation, billing, and coding training manuals. I am a contributing writer to numerous publications and journals. I'm a guest speaker at many state association conferences nationwide. In addition to chiropractic coding and compliance, we also teach acupuncturists and physical therapists on proper billing, coding, and documentation. So let's begin. Modifiers. So, as I mentioned earlier in the opening, the AMA owns the copyrights to the CPT codes. Well, they also own the copyrights to the modifiers. So the AMA is the official source for rules and guidelines regarding proper CPT code and modifier use. Now, a modifier allows a provider to indicate that a service or procedure has been altered by some sort of circumstance. Modifiers enable healthcare professionals to effectively respond to payment policy requirements. The careful application of modifiers prevents the necessity for a separate procedure. So modifiers, in certain instances, are required to be used. Now, if it were up to me, I would say don't use modifiers at all, because again, when you look at the definition here, a modifier tells the health plan that the CPT code has changed. Something's unique, something's different. So that alerts the payer that something unusual occurred. So if I could get away without alerting the payer that something unusual occurred, I would prefer that. However, there are certain modifiers that if you do not use them, you won't get paid. And then there are certain modifiers that if you do use them, they trigger audits. So it's a slippery slope here with modifiers. And then there's a couple of modifiers I'm going to go over with you in a couple of minutes that have been causing a lot of denials and a lot of confusion. So hopefully we'll be able to clarify that today. So modifiers may be used to indicate a lot of different things that the CPT code has been altered. Like there's a professional component, a technical component. The procedure was performed by more than one provider. Only a part of the procedure was performed. The service was increased or reduced. A bilateral procedure was performed, plus many, many different types of situations. We're not going to be able to cover all of the situations. We're going to go with just the most common modifiers seen in chiropractic practice, and some of these also apply to medical and physical therapy practices and acupuncture practices. So let's begin with 25. Very important modifier. Modifier 25 means a significant, separately identifiable E&M service was performed. An E&M service. So modifier 25 only goes on evaluation and management services. What's an example of an evaluation and management service? There you go. You see on your screen 99213. That is a mid-level, considered a detailed re-examination or an established patient E&M code. There are 5 established patient E&M codes, or some of you may be calling them the re-exam codes, 99211 through 215. So 99213, right in the middle. This is where a patient may come in where something unusual occurred. You would not use a re-exam code if this is a routine visit. So if you walk into the room, you say, "Hi, Mrs. Jones," and she says, "Well, Dr. Kotler, not so good. I have a new condition, or I've had a flare-up of my existing condition, or I don't feel like I'm getting better as fast as I should." There's a few instances, patient had a new problem, exacerbation, or is stayed the same for too long. Those are indications to do a reevaluation. And if you're also going to do a procedure like a chiropractic adjustment on the same day, that's where you would be required to put the 25 modifier on the reevaluation code. Again, the 25 would not go on the chiropractic adjustment code. Next, 59, Modifier 59. It means there's a distinct procedural service was provided. Under certain circumstances, it may be necessary to indicate that a procedure was distinct and independent from other non-E&M services. Your documentation must support that a separate structure was treated. One of the most common examples is right there on your screen, 9714059. There's something called the CCI edits, which we're going to get to in a couple of minutes, that state a chiropractic manipulation and manual therapy should not be performed in the same anatomic site. If it is, it becomes non-payable, becomes mutually exclusive. It's a duplication of service in the eyes of the CCI edit people. Well, that's silly. It doesn't make sense, right? Some of these rules just don't make sense. And I scratch my head, but I don't create these rules. I just share them with you and try and explain them to you. See, I don't understand why if Mr. Wilson comes in with neck pain and neck stiffness and you want to do some manual therapy on the neck, let's say like myofascial release, and then you also would like to give the patient a chiropractic adjustment or manipulation right in the same cervical region, what's wrong with that? Why is that an issue? Well, it is. Now, if you do the manual therapy on the neck and you do not adjust that region, and let's say you do a manipulation on the lower back, that's where you would add the 59 to the 97140, indicating that's a separate structure and you have a separate diagnosis. So I mentioned the CCI edits. This is a federal program that maintains a system of coding edits. The purpose of these edits is to electronically detect codes that should not normally be used together. So the CCI edits require not only manual therapy, but massage and NMR be performed in a separate anatomic site. So fine, that's fine. If you do it, it's okay. You're going to use the 59 modifier to indicate that it's a distinct procedure and it's being performed on a different anatomic site than the CMT. So if you use modifiers properly, you shouldn't have any issues getting paid. Now, if you use modifiers incorrectly, then you could have some problems. For example, I know some doctors that will use the 59 modifier even though they did not do the manual therapy in a separate anatomic site. So because of this confusion with Modifier 59, there have been some reports, there have been some data, there's been analysis, and an OIG report a few years ago found that Modifier 59 was being used nearly incorrectly, nearly 40% of the time, resulting in over $50 million in overpayments. So that's why it became a frequent target. So it's interesting. Modifier 59 is one of those rare modifiers that bypass the CCI edits. Think about it. If you submit a claim with a spinal CMT code and manual therapy 97140 without the 59, what's going to happen? The claim will get bundled and you'll only get paid for the manual therapy. For the chiropractic adjustment. They'll bundle the manual therapy. Now, if you resubmit the claim with the 59, the claim gets paid. You see? So the 59 modifier bypasses the CCI edits. It's one of the rare modifiers that do that. So that's why this code gets used incorrectly. And that's the reason why a new subset of modifiers have been created because of the 59 confusion. They're called the XESPU modifiers. The one that makes the most sense is XS, separate structure, So the manual therapy is being performed on a separate anatomic site. Now, do not use the XS modifier unless you're having a problem with the 5.9. See, if you understand the 5.9 modifier, you're using it properly, and you're getting paid, don't change anything. If you are audited, you should be able to prove it without an issue. Now, if for some reason your claims are getting denied with the 5.9, even though you're using it properly, it could be because that carrier has switched to the XS. Some carriers have already switched to the XS, but do not switch to XS unless you are notified that the 5.9 is not being used properly. Now, the 25 and the 5.9, boy, I'm getting these emails and doctors and staff from all over the country over the past few months saying, Dr. Kotler, why are my claims getting denied when I use modifier 25 and 59? Prior to this year, I wasn't having a problem. Since the beginning of this year, my claims are getting denied. Well, recently, many providers have begun to experience a downpour of denials, particularly from Blue Cross Blue Shield plans, because from what I've heard, they've implemented a new code auditing enhancement, which would be clinically validating modifiers. This new software program focuses particularly on 2559 on the XESPU modifiers, resulting in claim rejections. These rejections include both E&M services and CMT, whether or not physical therapy services are included. So this is affecting not only chiropractors, many different types of providers. So claims using these modifiers are being denied at a high rate. So according to the American Chiropractic Association, the denials state the modifiers are used inappropriately. In other cases, providers have received letters stating their utilization of modifiers is higher than the average. Well, listen, this is a free country. Last time I checked, if you're busy practicing 500 visits a week, you might be using manual therapy. You might be using modifiers more than someone that's seeing 50 a week. So you shouldn't be penalized for that. Regardless of the denial reason shown in the EEB, it seems that this is based on the new editing software, and many state associations are trying to work with the payers to resolve the problem. So my immediate recommendation is, if you're getting denied with the 25 modifier on your E&M codes, resubmit without it. Your documentation will prove that you're doing it right. And what does that mean, doing it right? You're doing it for a separate and distinct reason, like a flare-up, a new condition, or the patient is not improving. Best recourse is to appeal and keep appealing. Perhaps if the health plans are flooded with appeals, they'll revisit this erroneous edit. Modifier 26, professional component. So when you take x-rays, if you take x-rays, or an imaging center takes MRIs, CT scans, there are two components: technical component, which is taking the films, and the professional component, which is reading the films, going over them with the patient. So sometimes you separate the technical component from the professional component. That's where you would use the 26 modifier. 51, multiple procedures. When multiple procedures other than E&M services are provided, you may have to use the 5.1. Not needed as much as it used to. The example I have on your screen there is the extremity adjustment, 98943. Some carriers, no matter what you do, if you bill a spinal adjustment and an extremity manipulation without the 5.1, they'll bundle the extremity adjustment into the spinal and only pay you for the spinal. Well, the way around that is to add the 5.1. See, in my opinion, if a patient comes in, let's say, with a shoulder problem, and you're going to adjust the shoulder, minimum of 3 things on the extremity. A complaint, for example, Mrs. Jones says, my shoulder hurts. I was playing tennis over the weekend. Jot that down. Patient complaining of shoulder pain and shoulder stiffness. Examination is done. Restricted range of motion, tenderness, tightness, muscle spasm, inflammation, swelling, and then a diagnosis. So a minimum of 3 things on the extremity. If you do that, you should get paid for it, hopefully. And if you're using the 5.1 and it's not working, then bill without it. Now let's go through some Medicare modifiers. Let me first give you a little Medicare Q&A. Well, the question I was going to ask is, can chiropractors opt out of the Medicare program? The answer is no. Chiropractors cannot opt out of the Medicare program. There's your source. If you want to look into that a little bit more, go to the Medicare Benefit Policy Manual, Chapter 15, Section 40.4. States chiropractors cannot opt out of Medicare. Now, some doctors will do this inappropriately. They'll tell their patients, I'm not in Medicare, don't worry about it, I'm not in Medicare, just pay me, we don't bill Medicare, I don't have a Medicare number, I don't even know if I'm enrolled with Medicare, I haven't billed Medicare in over a year, but I take Medicare patients, they come in, they just pay me cash. The Medicare patients are okay with it, they just pay me cash and I don't submit the bill. Can I do that? No, absolutely not. Chiropractors not enrolled in the Medicare program should not be seeing Medicare patients. You cannot opt out. Opting out is a private contract with the patient. Now, some states do allow it, but there's a little bit of, some states allow private contracts with non-Medicare patients. So just be careful with that. Now, if you are not enrolled in the Medicare program, you're not even allowed to use ABN forms. So chiropractors not enrolled in Medicare cannot issue ABNs to patients. You could look that up if you would like. That's Medicare Claims Processing Manual, Chapter 30, Section 50.3. Oh, here's a document that states, this is right from Medicare. It says, doctors of chiropractic may not opt out of Medicare. Chiropractors may not opt out of Medicare, noting that opting out and being non-par are not the same things. Chiropractors may decide to be par or non-par with regard to Medicare, but they may not opt out. So let's go over a couple of Medicare modifiers, the major ones. AT. AT means active treatment. AT tells Medicare that the care was medically necessary according to the Medicare guidelines. AT is only used on spinal manipulation codes. That's the only code covered by Medicare. Modifier GA. GA notifies Medicare that an ABN was signed and you have it on file. They don't know why unless they ask you for your notes, but the most common reason is maintenance care. So once the patient gets to maintenance care and the patient says, yes, I understand Medicare won't pay, I still want to come in, then you have to, by law, you have to show them the ABN form. ABN is required for covered services. If the patient signs the form and they check option 1, which means they want you to bill Medicare anyway, even though it's not going to get paid, then you would bill it right there, 98940 for 1 or 42 with the GA modifier. GY, I would recommend you use this on all non-payable chiropractic services like exams, x-rays, therapies. See on your screen, 99203 GY, also the 25. You could have up to 4 modifiers on one CPT code. Now, Modifier GP is causing a lot of problems too. GP means the service was delivered by a physical therapist. Wait a second. Chiropractors are not physical therapists. Why should we have to use the GP? Well, it's because some Medicare carriers are denying the modalities and therapeutic procedures. They're getting rejected. They're not getting processed properly when sent in by a chiropractor without the GP. Again, it's one of these things that don't make sense. So, are your claims for modalities and procedures getting rejected? Now, Medicare doesn't pay for modalities and procedures, but many patients have secondary plans that will pick up the therapies and the modalities. So we wanted to go to Medicare to get processed properly, but they're not recently. So modalities and procedures provided by chiropractors, although non-covered, should be submitted with the GP and GY modifiers. If submitted without the appropriate modifiers, the claim will get rejected, and then the financial liability transfers from the patient to the provider. So this is what it should look like. Example, electrical stim, GP, GY, manual therapy, GP, GY, and the 59. I like using the GP first because of all the denials that are occurring. Technical component, yeah, that's the other part of the X-ray. I mentioned earlier the professional component. Then there's a technical component. TC. Now we have some other modifiers here. RT, pretty straightforward, is right. LT is left. Example, you might have to use that on orthotics, L3020. With TENS devices, many health plans want you to rent the TENS device for a month for this trial period to see if it's working. During that trial period, you're going to use the RR for the rental. After a month, patient says, I like this TENS device, it's helping me. Then you would bill the insurance company for a new TENS device, the modifiers NU. And then we have modifier Q6. This is services furnished by a locum tenens provider. So let's say you are going on vacation and you want to have another chiropractor come in and treat your Medicare patients, for example. For all the services you render, you would add the Q6. Your name, even though you're going on vacation, your name stays on the claim. The covering provider is treating the patients. The covering provider's name is in the note. You're not hiding that the covering provider is treating the patient. Just for billing purposes, it makes life a lot easier if you use the Q6 modifier. All right, just a few closing comments. Please check with the carriers you bill prior to submitting claims to make sure it's compliant. We can't guarantee this information will guarantee payment from any insurance company or patient. Target coding is not responsible for any laws, rules that may change following this presentation. And you know they change all the time, right? So it's important. Do your best. Stay on top of these changes. Attend seminars. Attend webinars. Join your national and state professional associations. I want to thank everybody for attending. Here's my contact information. You could email me directly, Dr. Kotler at targetcoding.com. There's our website, targetcoding.com. Telephone number, 1-800-270-7044. Our HIPAA secure fax number is 1-844-831-2347. We are on all social media platforms. If you're looking for some coding tidbits and some of the specials we run, check out Facebook. Follow us on Instagram and Twitter. Like us on Facebook. Check out our YouTube channel for our free videos. For example, let's say you really like this video, this presentation, and your CA or another staff member was not able to attend in about 24 hours. Go to our YouTube channel and you could have your staff watch it again. Besides the webinars here at Target Coding, we also put on seminars. We sell videos. We have 12 training videos that we sell. They're all on our website. We do on-site consulting. We offer coaching and membership programs. We offer hourly consulting. We have a forms packet. It's 80 chiropractic, acupuncture, physical therapy, HIPAA, and Medicare forms. Even though you have software, a lot of doctors, I know you have great EHR software, you still need to have certain forms signed by the patient, and most of the software companies do not provide you with the forms that are needed in certain instances. Oh, yes, we implement HIPAA compliance programs. We offer billing and coding policy manuals, Medicare compliance manuals, HIPAA forms. We have a guidebook, tremendous guidebook. It's the book on the best ICD-10 and CPT codes to improve reimbursement. We show you how to get paid. This isn't a book of just codes. You can buy a book anywhere. You can get codes online for free. This is a guidebook. Specifically tells you which codes pay the most visits, the order in which to submit the claims to maximize reimbursement. For some of the most common diagnosis codes, it shows you how to justify the codes with chiro, ortho, neuro tests. For your CPT codes, it shows you how to justify using them with the clinical rationale for all of them. Here's an excerpt of the book that shows you if you're going to diagnose a patient with cervical radiculopathy, all right, do a little Jackson, a little shoulder depression. You might want to check reflexes. That's an advanced diagnosis. You need to do a few things to substantiate it. Years ago, if a patient came in and said, Dr. Kotler, my back hurts and I have pain down my leg, I just diagnosed sciatica. I didn't do any ortho neuro tests. It's changed. A lot of things have changed over the years. If you're in practice more than 3-4 years, a lot has changed over the last 3-4 years, especially with ICD-10 because of the increased specificity. And yes, we also offer billing and coding training manuals for chiropractors, acupuncturists. We just got approved as a NCCAOM provider. That's through the National Certification Commission on Oriental Medicine. So now we do continuing education programs for acupuncturists. We do training manuals for acupuncturists, billing and coding policies for acupuncturists, HIPAA programs for chiros, PTs, and acupuncturists, and medical doctors. We have memberships, forms. We offer a lot of services here at Target Coding. So our next acupuncture webinar is coming up. Physical therapy webinar. All right, so again, I want to thank everybody for attending. Here's my contact information. I hope you learned a lot.